It was the very first case that I looked at. They sent up an unfortunate bicyclist that got hit by a car at speed, obviously died. And that was the first postmortem CT that I looked at in this arrangement. And I'm used to looking at very banged up people, being a trauma radiologist here at a level 1 trauma center. And this case was kind of a Uber on that, essentially. Broken bones, a lot of trauma. But then I saw, he also had, a chest full of blood. And with more examination, I hypothesized that this person's aorta had ruptured. And that was the cause of their death.
We're here because we're curious about medical imaging or have a hunger to learn more. What can we learn from each other, and how should we prepare to tackle the challenges ahead? I'm Chris St. John, and join me today as we rethink imaging, a podcast by Imalogics. Welcome to the show. Welcome back to Frame by Frame Rethink Imaging. Today, actually by popular demand, we have Dr. Kalpana Kanal back with us, the Director of Diagnostic Physics and Imaging Physics Residency Program at UW. Dr. Kanal led the ACR CT Dose Index Registry as Vice Chair and Chair. Since 2017, she has served as the ABR's Diagnostic Medical Physics Trustee. And joining us as well is Dr. Jonathan Medverd, the Chief of Radiology at Harborview Medical Center and Associate Professor of Emergency Trauma and Radiology at UW. Dr. Medverd specializes in emergency trauma, body, and musculoskeletal imaging, focusing on optimizing imaging workflows and image-guided procedures. Thank you so much for joining us on Frame by Frame, to you both. When I sent by popular demand, what I meant was Dr. Kanal and I originally recorded an episode on the Dose Index Registry, and at the end, she let me know that she's been working on something different, this Postmortem CT, and we got a lot of feedback from folks, and we wanted to do an episode where we really dive into it rather than just covering it. And so for the listeners who are new to the Postmortem CT, not to the, but to Postmortem CT, could y'all give me like a little bit of an elevator pitch for the project? What is the problem you set out to solve? How does your collaboration work? And where does the program stand today?
Sure. Why don't I get started and then Dr. Medverd can talk about collaboration. We started this work actually almost 6 years ago. And the goal that we had was to leverage technology to help with cadaver imaging so we can determine using CT the cause of death. Do we really need to do an autopsy on every cadaver to determine the cause of death, right? Because that's really what reason we do autopsies. So that was one reason. Can we leverage technology and assist our forensic pathologists in making that diagnosis and helping them using the CT? The other concern also is in the forensic pathology world, there's a shortage of professionals going into that field, who wants to do autopsies as part of your career. I think so that there's been a significant drop in their numbers. And I feel that CT could then help, again, fill some of that gap and the lack of staffing that they're going to encounter as fewer and fewer professionals go into forensic pathology. I'll let Dr. Medverd comment on the collaboration.
The collaboration has been truly wonderful from a professional standpoint as well as an operational glide standpoint. Harborview is a county-owned hospital that, and the county also has a whole different bureaucracy, different office that involves the medical examiner's office. And it just so happens that both our hospital campus and the medical examiner are on the same campus. They're basically our outpatient building, radiology has third floor, and the medical examiner's on the second. I didn't even know that before this relationship started because we were that separate. However, given mutual interests and mutual goals, we've really developed a tight bond and have worked to overcome many hurdles to get this collaboration and program together.
I'm curious, what was the first moment when you noticed that 1+1 was more than 2? What did you see on the scan?
To tell you the truth, Chris, it was the very first case that I looked at. In the early days, we were not doing consecutive cases. We were doing selected cases by the medical examiner, and they sent up an unfortunate bicyclist that got hit by a car at speed, obviously died. And that was the first postmortem CT that I looked at in this arrangement. And I'm used to looking at very banged up people, being a trauma radiologist here at a level 1 trauma center. And this case was kind of uber on that, essentially. A lot of broken bones, a lot of trauma, but and that could be picked out very quickly. But then I saw, we also had, a chest full of blood and things like that. And with more examination and leaning on skills I have from the living, I hypothesized that this person's aorta had ruptured, and that was the cause of their death. And in those early days, we were doing autopsies as well, so there was that one-to-one correlate, rad-path correlate, and it was confirmed, not just that the aorta ruptured, but at the location I had predicted. And I saw then the power that, okay, we could have maybe prevented a traditional autopsy in this case, by using the CT. And it's gone from there.
How many cases have you scanned so far?
Well, a couple of weeks ago, we have scanned about 184 cases. We started on July 18th, 2022. So we're coming up on our 3rd anniversary. So we've scanned, as I said, about 184 cases. And if you want the analysis, I would say about 45% of those cases we did not have to do an autopsy on. The CT gave us significant results and said, you know what, here's the diagnosis. Dr. Medverd had confirmed diagnosis that the pathologist didn't need to do an autopsy for at least 45% of those cases.
You have to distinguish between the iatrogenic and the natural actual causes when you're reading these images, right?
Yeah, that's a difficult question. Anatomy is anatomy, but interpretation of living versus deceased individuals has been a definite learning curve. We're building our experience on the artifacts. Common things become common even in dead people. Gas is difficult to interpret sometimes. When is there too much gas because of trauma or disease? When is gas just because of natural decomposition? That really becomes an art, because some people die in a 70-degree room and other people die in a 40-degree sidewalk. And the trajectory that they take is much different. With trauma, oftentimes a traumatic rib fracture looks different than let's say a CPR, a fracture related to CPR, so that, what did the accident cause versus what did the attempted resuscitation cause? Usually you can tell the difference because just like in the living, it's pattern recognition. And typical patterns usually will draw out a clear picture, and particularly when neighboring patterns all fit a story, then you can become more confident.
So, I mean, it's so cool. And so as y'all are preparing to transition from the pilot into a full service, what operational hurdles do you anticipate running into?
I think we've kind of already passed the hurdle point, because as we speak, the CT scanner is being installed in the ME office right now this week. It arrived on Monday. The operational hurdles, just to kind of reiterate, for this whole project to get started, we had to figure out initially who the players are, who do we talk to, who are the decision makers on the pathology side. Are there people interested on the radiology side? So when I started this with my other physicist colleague, David Zamora, we started 6 years ago. We started at the main campus, and we had to figure out who are the pathologists, who do I need to talk to? Are they even interested in forensic imaging? Those were all the hurdles we worked out. Now, as we came to Harborview and the ME office saw the value of this, the hurdles to work out was, the money. Where do we get the money for the scanner? How do we support the staff that's reading the CTs, the radiologists? What else do we need the money for, right? Do we need money to support the whole program? How do we do the training? How do we set up our day-to-day? When do we do huddles for the radiologists to look at the scans and figure things out? Those are the type of operational hurdles we're working out now. Where do we store our images? How do we connect with UW being a different entity, a university setting, hospital level 1 trauma setting, and King County being governed? It's a government agency, right? So just the way things are done on both sides are different. And how do we do that? So one thing we have done is we do a touch base meeting every month to talk about our issues and hurdles and getting over them. And we've been doing that for more than a year to get ready for the CT scanner that arrived yesterday.
You have to have some sort of complex understanding between UW and the King County ME office, right? What was the process of coming to that understanding like, and what would you suggest for others who are looking to streamline a similar process?
John, do you want to take that on?
I think step one has to be the relationship. Without the relationships that we've built here, I do not think we would be able to be where we're at. And relationships sort of, in my mind, becomes an umbrella term, for trust. Through that relationship, we've learned to trust each other. We've honed a common vision. Are there facets of that vision that radiology looks a little bit differently on than the medical examiner? Sure. Our needs, our strengths are both different. Our needs are different, but we both kind of have the goal to get to the same horizon. So that's good. So I think you need to meet the people in your neighborhood, so to speak, in quotes, and come to common vision, or at least common goal, and then work on it, coming to a common vision. And then you got to get to the nitty gritty. I wish if I were to do this again, I would come up with a more of a formal business pro forma right up front. There is data out there from our experience, there's more mature centers, like a very well-known one in New Mexico, that have published on some of the operations, some of the expenses, some of the savings, and a group could use that to model and translate to their environment and their unique situation, so to speak, and hopefully understand better the time and resource investment that are needed. I mean, with us, we were volunteering and we were following a goal, a dream, a vision, whatever you want to call it. And it would have been nice to be able to keep our bosses, to inform our bosses going into it, what the possible range of expectations were to be. And so if I were to do it again, I would do a napkin pro forma. It doesn't need to be a formal thing, but just get a sense there. Try to use literature to have ideas to mimic other experiences, and then I guess to come full circle, the relationship is key. If you don't have a collaborator on the other side, Certainly what I've learned, we need both the push and the pull in the same direction, going towards the same goal. If there was friction, I'm not sure how we would have fared, but there was very little friction. We worked together to eliminate friction. And then maybe I'll lastly say, in hindsight, the one thing that I would do is, in the spirit of volunteerism, to get things started, we didn't talk about or chose not to talk about any professional fee from the radiologist side, time of interpretation, time of protocol development, such and such. And I would probably, in retrospect, include that so that placeholder, even if it's $1, $1 a day, keep it so that placeholder is there, that acknowledgement is there, that it doesn't get ignored when things mature and there's opportunity to build a more rounded reimbursement or contractual structure. Then that's there already. You don't have to insert it because it's already in there as a thought. So that's one thing I guess I would say to folks. If I were to do it again, I would include a professional cubby.
If I may add to that, having a commitment from whatever your leadership is, and going into this with a commitment that there will be money to run the operation, right, and to set up the program. I think for any entity, once you get into that commitment should be there, because you don't want to get halfway through the process and then realize that there is no money to support the program. So I think that is what I would also highly recommend anyone who wants to get into this to do, is sit down with your leadership, people who do the money, and get a commitment that you're going to support the program. We are fortunate that we have this wonderful understanding, and even though we are not making any money right now, radiology isn't. We have the potential to do this, as a consulting, to maybe do consulting in the future when it's set up and establish a revenue stream. But we are doing it because we care and we are passionate about this project, because we think it's impacting the community. It's making a lot of impact. And at some point, CT might also show up in the court system, right? When our medical examiner does a testimony in a court case, instead of looking at gory images, they can look at CT images, which is so much better for not biasing the jury, right? It's much better than looking at blood and gore. So I think there's so much of an impact I feel on public, on community, on public health. That's why I got into it. I didn't get into it because I'm making money, right? I'm making no money. I'm a physicist. I'm not even a radiologist. John has value here. I don't have any value. Really the passion of what this brings to the world, to the community. And it's very, very common outside the US, so why not here?
Yeah, absolutely. I mean, and I feel like that community element, it goes into people's, it touches them in their belief systems a lot of times, right? Like, there are, like, haven't y'all done some cases where you can do a CT instead of an autopsy for religious objections, right?
Absolutely. We had some cases, and I don't remember the exact number, but we have had cases where the family objected to an autopsy, and we said, okay, we have a CT, which is non-invasive, and we'll still get the answers we want. And I think that has been significantly helpful to families and the community, that we can still get the answer we want without cutting open the body. So it's definitely, from a cultural point of view, emotional sentiment point of view, religious point of view, significant to have this alternate option to an autopsy.
In some circumstance, the medical examiner gets requests from families for sometimes religious, sometimes other preference reasons, that they don't want a body disturbed. And while they don't advertise that per se, They do want to honor those requests when the circumstances of the death allow it. For example, in a very straightforward, not many questions about the cause and manner of death, they might do that, but their hands might be tied if there's particularly suspicious circumstances surrounding a death where even in the face of a request to not disturb the body, they might feel compelled to do a full autopsy nonetheless, and be uncomfortable with CT only. Anything with a police investigation usually gets a traditional autopsy just to have the maximum information for whatever official investigation is going on. And when it can work, it's comforting for families, and they're very appreciative to avoid either the thought or the sight of a body being disturbed.
If y'all wouldn't mind a slight little pivot, I feel like you hinted a little bit at a future postmortem CT fellowship. Are there core skills and rotations that you would want to build into the curriculum for that?
Yeah, so this is something I'll comment on, and then I'll have John put on his radiologist hat and comment on. I'll put on my physicist hat. So this is something I really am interested in because I feel that, we are interested, the radiology side, the pathology side is interested. Why don't we train people to do both, right? You want this field to expand and grow and become popular, you need the radiologist and you need the pathologist. So having a fellowship where it could be a pathologist learning about the radiology side besides what they learn, or having a radiologist learn about the pathology side because they are already learning the radiology. So kind of combining the two, to me, would be fantastic. It's a solution to the problem where they can use both their expertise to grow this. Because this is, what we are seeing with only the 184 we have done has such an impact. So imagine doing this every day on every cadaver. So from my very naive non-MD point of view, I think why not? We should have a fellowship that will actually be a new area of study, and where we would combine the radiology principles and the pathology principles to grow it. And I've told John I'd like to do this before I retire. So we only have 3 or 4 years to do this, John. So that's my take on it, but I'll let John comment from his radiologist hat.
Thank you, Dr. Kanal. You covered most of it. There are advantages to knowing postmortem CT interpretation that benefits living interpretation. The way I've come to view it is that reading postmortem CT really adds a new facet, a new way to understand CT in the living, and vice versa. They really do complement each other. I came into this obviously having 2 decades experience as a radiologist for the living, and learned as I went the rules, so to speak, of postmortem CT. I think that in a fellowship, more of an educational program rather than a school of hard knocks is more preferred, and that is something that we now will have the opportunity to someday do, and I think we both have a passion to try to fulfill that. There's certainly a need for this work in our state and other states. There's a shortage of forensic pathologists. There's no shortage of deaths, and a fellowship to help inform well-trained and competent people in possibly a new future for forensic investigation is something that I think we're going to be doing. Maybe not tomorrow, but maybe next month.
And we've made a small step in that direction, Chris, by Dr. Medverd and I have established a forensic radiology rotation in our department. And that will be only for our senior residents, our 5 years. So they're done with all their, they're getting ready to graduate. And we're going to try it out this November. And Dr. Medverd and I actually wrote the content of that rotation, and at least on paper. We still have to work on making it happen. And we worked and partnered with our ME, Dr. Lacey, who's been very supportive of this whole work with us and is very, very excited about doing that rotation where we envision our resident with help with the reading of the postmortem CT under Dr. Medverd and other attending guidance, as well as go and shadow the medical examiner office pathologist and see how things happen on their end. And I think it's going to make for a very interesting rotation. I want to do it, and I'm not even qualified. I'm not a sure. But it just seems so interesting to me, right, that they would learn something they haven't learned in the 4 years that they've been here as a resident to read cadaver exams under the expertise of the attendings like Dr. Medverd, and then also look at the other side of the coin, the ME side. And I think it's going to make for a fantastic rotation. It's going to be a 1-month rotation. And we're hoping we'll have, people, it's an elective. They don't have to sign up for it. But we will have our first taste of that in November or so this year. And I think that will give us some good experience in seeing what works, what doesn't work, and how we can then build to make or to create rotations in that fellowship, a 1-year-long fellowship. So I think we've already taken a tiny step towards a fellowship. And I'm sure we'll learn a lot from that experience.
Yeah, and so this is, and forgive my naivete if this is a silly question, right? But these are full body scans. So isn't that a unique and interesting opportunity for, folks who are learning to read these images?
We certainly can scan from head to toe. And in fact, with homicides, we do. From the very top of the head to the end of the big toe. For most postmortem CTs, though, we do a head, neck, and torso, and then a portion of the legs. Usually the thighs and knees, and maybe a little bit into the lower leg. That's just easier that way. From a scanning perspective, and oftentimes if there's no question in the far lower extremities, then it's easy to do. We would maybe decide how much to scan beyond that standard based on the death scene investigation and the questions the medical examiner might have in their head.
Yeah, and so I mean, in those 40-something% of cases, postmortem CT alone was sufficient. Reducing autopsies. What are there any traits or any tells initially that might hint that a CT will be enough off the bat?
When the death investigation is pretty clear, an empty road, a car is found that hit a tree with one occupant that is now deceased. Simple story, no question of foul play. In those, maybe the person's drunk and had a good reason to lose control or something like that. In those situations, a CT often can do a great job making an inventory of traumatic injuries and very likely point to the cause of death amongst those injuries, or maybe a combination of those injuries leading to death. That is that kind of a case might be a good candidate to do a virtual autopsy, so to speak, avoid the traditional autopsy. You can combine that information with drug and alcohol testing of urine and blood, et cetera, et cetera. So it really is circumstance by circumstance.
You mentioned earlier, you have to figure out where you're storing these images, how you're storing these images. how are you storing and sharing these DICOM data sets between hospital PACS and the medical examiner's office?
So right now, we are storing all our images in our radiology packs, and the medical examiners can access images on Epic, which is, Epic, which is the whole patient management system. And also continuing forward, when they buy their scanner, which is currently being installed, the agreement between us is that they would still send their images to radiology packs. So it would still store everything in our packs. It's not that expensive now, storage of images, so we can afford to let that come to us. And then they would still have access to Epic. And then some of them are also faculty in pathology department, so they have UW email. So they have the potential of logging into our PAC system anywhere and being able to access the images as well. And for now, I think that's going to work really well between both partners, us having it on PACs. And we also do a every other month forensic radiology conference where we go through cases. So Dr. Medverd will log into PACS, he'll throw up the cases on the computer, on the monitor, and there's pathologists and radiologists and physicists in the room, and we are looking at interesting. So they have the option there too, as he points out, interesting things that they're interested in. They can go look in Epic as well. They can always come and visit us in the radiology reading room. It's not that far. I think the biggest ease of doing this project is they're right across the street from Harborview. So it's not like you have to travel miles. In 5 minutes, I can be in Dr. Lacey's office, or he can be in Dr. Medverd's office. Very, very convenient. And I think so far that's the plan we have of storing the images and having them access via Epic.
I might just add a thank you to our radiology department chairman who has supported us in the use of our department's PAC storage. His support and has been pivotal to getting this program off the ground. He let us know that we didn't have to worry about money or time or cost of the PAC storage in that regard. And for that, we're all very thankful.
And may I also add, with respect to a question you asked earlier about hurdles. So yes, we're saving it in our PACs, but we are University of Washington PACs, a network, and they are King County network. So we had to get people on both sides, our IT, their IT, and initially, just trying to figure out who the players are. Someone is not responding, they would come to us. Okay, no one is, so that if I just recall that this is one of the hurdles that you need to also think about if you're working with two different entities, even though what Dr. Medverd said that great, we can use our PACs and thanks to our chairman, but we still have to make it happen. So the hurdles were the IT team, both IT teams trying to talk to each other, making sure they're available. All of that were also hurdles that we had to overcome, and now things are finally smooth. But initially, there were some rough waters to navigate, till we figured out, who's the IT person we need to talk to? Are we meeting all their needs? Are they meeting our needs? Firewalls, access, it's always dealing with IT is all those issues that you have to think about.
Absolutely. I was going to perhaps make a joke. I respect the IT teams of the world, but I guess I will also say it is unsurprising that was one of your hurdles. And I say that with respect to all of the IT workers out there. I respect and appreciate what you do. Also, I am unsurprised to hear that. It's complicated. Things are complicated.
Not the people, it's the complicated systems, yeah.
So this is very common in Japan, UK, Australia. They scan each and every cadaver in Japan, right? Why can't we do this in the US? I mean, we are already seeing with the very small data that the number of cadavers we have scanned, the benefits. So why is it such a hurdle, right? I'm sure Dr. Medverd will comment on that from his perspective. From my perspective, I think, just initially to figure out all the relationships and who's doing what to get a program started is a hurdle. But I also think the biggest issue in my perspective is billing. we can't make any money out of this unless there is a billing code, right? Um, so how can we bill and make money? A lot of these other places like Japan, the government supports the whole forensic center. Um, so maybe we need to look at that from that perspective. In America, here in the US, we only have 2 or 3 centers who are doing this a lot. But the rest of us, maybe some of us are doing it, some not so much. It's getting a little bit more popular in the medical examiner offices, but I think the main hurdle from a radiology side, who I feel are the experts in reading a CT, is the billing. Why would a radiologist dedicate all their time to doing this if they can't count it towards RVUs or get paid for it from billing perspective or even a professional fee? We are doing it now because we want to get the program started, right? But I don't expect Dr. Medverd to read this indefinitely without, pro fees or billing for our postmortem CTs. It's still time on the scanner. So I think that's the one challenge in America, and I hope we can overcome in the next few years as this gets more popular.
I would agree with that, Kalpana. Absence of a billable code for postmortem CT or postmortem MRI, for that matter, is definitely a strong contributor to why postmortem imaging is not a big practice here in the U.S. I will say, though, that since we are in such an infant stage at this point, it's a real opportunity to build something that benefits the society and isn't just a potential profit-chasing vehicle. If we construct backwards from the need back to the service, hopefully we can find an efficient way to meet this an endless stream of decedents with a always challenged resource pool. And so figuring it out in an efficient way in this day and age where everything costs too much, it seems, is a real opportunity for our society, I think.
From a benefit perspective, we have only been talking about diagnosis, right, Dr. Medverd? But the other benefit would be in cases with, diseases and infectious diseases where you don't have to cut up a body and expose the pathologist to it, right? The CT could be very helpful. During COVID, right? If we could do a CT, which we did to determine COVID, similarly for cadavers, right? Instead of opening it up and getting exposed, using this technology from that hat for now, not thinking diagnosis, but how can we help in world problems, infectious diseases? We don't want our personnel to be exposed to that, right? So using the CT instead of cutting open a body and being exposed to chemicals. I think one of the cases that we had here in King County, one of the pathologists got back to me and said CT diagnosed a ruptured and cerebrovascular aneurysm in an embalmed case where they did not have to do autopsy and expose the pathologist to toxic chemicals. So, I mean, if you open your mind, there are many different applications. We are focusing on diagnosis and cause of death, but there are so many advantages to the population, to the pathologist from doing the CT and not, opening the. So there's a world and population impact. As Dr. Medverd said, we have to approach it maybe from that angle and see how we can, make this more popular or advertise it, if you will, that, hey, why are we not doing this cool stuff, right? It is cool.
Yeah, I think this will inherently take off because it's a hybrid model. It combines imaging with traditional forensic science. It's less expensive. And if savings are similar to the 45% avoidance of autopsy that we found so far, that savings can be directed into other resources, whether that be more imaging or staffing services or needs on the ground.
Yeah, you mentioned cost, and I'm just going to, one more comment real quick. Complex autopsy costs around $2,500. Routine autopsy costs around $1,900. And external is about $900. So, you can just think if you didn't have to do a complex autopsy, which is $2,500, and do a CT instead, right? There might be potential cost savings too. So you can even think from an economic and financial point of view how this would help whoever is doing it, basically.
Yeah. And so, I mean, let's say a mid-sized county wanted to replicate your model tomorrow. What would step one be for them, and what rookie mistakes would you tell them to watch out for?
Since I started it over here, let me take first stab at it, and I'll have John comment as well. When we started, really the first step was figuring out the players on both sides. Who do I talk to on pathology side? Who's a medical examiner? What is the after-death investigation service processes? There are different depending on whether it happens in the hospital, does it happen in the field. Dave and I, my colleague, David Zamora, who's a medical physicist, and I had to figure all this out. And I think that first step is, okay, I want to do this. Okay, let me find the players. 2, what is the plan and where's the money coming from? Because whatever you say, I think if you do not have a plan for the future to have money and resources, it's going to fall apart very quickly, right? So I think we really have to start with just figuring out who the players are. Who do I talk to? Are they going to be interested in this? What's the point if radiology is interested and pathology is not, right? If the ME is not interested, there's no point for us being interested. So I think finding your players, like-minded people, is the first conversation you have. And I had like these 2 or 3 meetings with these really smart people on both sides that I didn't know, but I had to bring together to the table and have a conversation about this, including our chairman, of course, Dr. Sani, who presented the vision of the department. So I think the first point to me would be, to any hospital, would be, figure out who the players are, have a conversation, and then take it from there.
I agree. There needs to be a vision and a plan, but really everything needs to start with a relationship. With that can come trust and the opportunity to build towards a shared vision. And then also, I think one needs at least a backup napkin pro forma. You need to know a little bit about costs, a little bit about expenses, a little bit about where your pain would be if volunteerism, can't carry the full day. So coming up with a pro forma to understand how to fill at least basic needs of each side would be useful. Luckily, we built a very strong collaboration, very trusting relationship. So we've been able to touch through that. But before getting in, it is good to test how deep the water is for you.
And John, we wrote the vision statement within a couple of months of starting on this. So Dr. Sahani, myself, and Dave wrote this 6 years ago, or we have an actual vision statement on this project. So we started right away, and I think that brings clarity to what you want to do. We have come a really long way. I have to say how proud I am of the team and all of us who are involved in the collaboration, and everyone being so involved and interested. And I can't thank the medical examiner office enough for being supportive of radiology, who wants to do this. And of course, my partner here in crime, Dr. Medverd, who is so many hours reading the Postmortem CT along with other 2 or 3 radiologists we have that are reading, on his own time, right? We're not getting professional fee for that, but he believes in the same message and he believes in this. And so we are doing this. And we are doing great so far.
Seriously. Well, and the way that y'all talk about it, like it is inspiring. It's like that's genuine. It is passionate people speaking passionately about things they are passionate about is always going to inspire others. For that little bit of poetry for me using the same word over and over again. But thank you very much. Well, I think that is as good of a place as any to wrap up this conversation today. I don't want to keep y'all any longer. But Dr. Medverd, Dr. Kanal, thank you both so much for coming in and joining us today on Frame by Frame. It has been I mean, it's such a it's been a delight because you're passionate people speaking passionately about the things you're passionate about. And so thank you.
Thank you for giving us an opportunity to talk about this project that we are very passionate about. And I hope the vision I have is, if I may, that this takes on in the United States and we do more and more of this in the country to benefit, humanity.
Thank you both so much. Rethink Imaging is brought to you by Imalogics. Here, you'll find engaging interviews with thought leaders, experts, and patients, sharing stories that showcase the transformative power of medical imaging. To discover how Imalogics is rethinking imaging in healthcare, visit imalogics.com. Be sure to subscribe to Rethink Imaging on Apple Podcasts, Spotify, or wherever you listen. And from all of us here at Imalogics, thanks for tuning in.